Okay, so we're going to discuss a couple different procedures to treat those patients that have had mallet fingers that haven't healed correctly and still have a persistent lag. We call those the chronic mallet finger. So before discussing the procedures, it's important to understand the intricate extensor mechanism anatomy. So here we have the extensor mechanism drawn out in schematic form. We've got the bones. We have the metacarpal, the proximal phalanx, the middle phalanx, and the distal phalanx. The extensor mechanism starts with the extensor digitorum communis, right, the back of the hand. That tendon comes down over the metacarpals and will attach into the dorsal base of the middle phalanx here in what we call the central slip. Okay, so that central slip attaches to the base of the middle phalanx. Before it actually attaches and proximal to the PIP joint, the lateral bands take off from the central tendon and then reconstitute over the distal interphalangeal joint and attach to form the terminal tendon, which is what's torn in a mallet finger. And to add a little bit more to the complexity, the small little muscles in the hand, the intrinsic muscles, the interossei and the lumbricals, also will give off little tendons that contribute to the lateral bands and help form that intricate extensor mechanism. Now when we look at it on the side view, what we see here, again, here's the distal phalanx, the middle phalanx, and the proximal phalanx. You have the flexor tendon through the fibroosseous sheath. Here's the A2 pulley and the A4 pulley. That flexor tendon is palmar. Here you have the extensor tendon that comes and attaches, okay, all the way on the middle phalanx here. Before the PIP joint, it will split off into this lateral band that passes still dorsal to the axis of rotation, attaches to the lateral band on the other side of the finger, and then attaches to the dorsal base of the distal phalanx. Now another final unique piece of anatomy is the oblique retinacular ligament. So you all heard about the oblique retinacular ligament reconstruction is one of the procedures that we do to treat chronic mallet fingers. Well, this is what that ligament is. Okay, it was described early on in the 1700s, and it's not a tendon. It's a static structure. It attaches from the proximal phalanx and the actual fibroosseous sheath. It passes palmar to the axis of rotation of the PIP joint here, and then it'll actually travel up and it passes dorsal to the axis of rotation of the DIP joint and inserts into the side of the extensor mechanism and then the distal phalanx there. And this is an important structure when we start talking about how to reconstruct the chronic mallet finger.